Hello everyone and welcome to the Simulating Healthcare Workshop series. This month we are looking at using simulation for facility planning within healthcare, and we're joined by two great speakers. We've got Graham Prelwitz and Lance Milberg, both from Memorial Health Systems.
Fantastic. Thank you so much for that introduction. As was mentioned, my name is Graham Prelwitz. I am an Operations Improvement Project Manager for Memorial Health System. With me in the room is Lance Milberg, who is our System Director of Decision Sciences for Memorial. To give you just a quick background, Memorial Health System, we are located in Springfield, Illinois. We have 4 total hospitals, as well as 3 other outpatient and specialty affiliate programs. We do have our 500-bed flagship hospital located here in Springfield, Illinois. And what I'm going to walk through with you today is, first, how do we here at Memorial utilize simulation, specifically the SIMUL8 software. And then I'm going to walk you through sort of the 4 questions that we ask when we're going through and we're creating a model. The first is we want to know our inquiry. The second, we want to know our process. We want to know our space. And last, we want to know our data. And I'm going to attempt to show you how we've used SIMUL8 as well as these 4 process steps during our facility planning process to make sure that our construction and planning phases go smoothly, go efficiently, and have great outcomes. And then lastly, I'm going to cover 2 case studies that we've had here at Memorial and demonstrate how we've used these 4 questions as well as the SIMUL8 software to build models that have had an effective use for our planning committees. So first, why do we use SIMUL8? For those of you joining us in the United States that I can speak for, we have seen care that is constantly transforming. So a lot of this care is trending towards an outpatient environment. We're seeing a lot of these freestanding emergency departments. We're seeing a lot of these quick clinics that are popping up. So with a lot of this care trending towards that outpatient environment, we need to figure out ways to build bricks and mortar buildings to be able to care for those patients in a different setting as opposed to the inpatient traditional setting that we've seen in the past. We've also seen advancements in technology, so we've been seeing a lot of telehealth as well as these virtual visits that are coming about, and advancements in technologies along the bedside where we're seeing a lot of these procedures that used to be done that had 3 to 5 day inpatient stays afterwards. We're seeing those completed in an outpatient environment now where patients are coming in and going home that exact same day. And so ultimately we want to use simulation and specifically SIMUL8 software to ensure that we're creating a process and system that is safe, that's efficient, that's repeatable, and ultimately that's sustainable for the care that we provide and the patients that we are serving. And looking at the end goal sort of for SIMUL8, we've utilized SIMUL8 for about the past 4 to 5 years here at Memorial. And really what we're looking at is in our long-term goals over the next 5 to 10 years, we want to see if there's the ability to continue to build models in different care environments for our patients and have the ability to connect all of these models so that way we can run models for patients throughout their entire care continuum, whether it be for patients that are being referred to us from an outpatient clinic or patients that are possibly coming in through our emergency department, and see how those patients flow through our inpatient unit as they're being discharged and as they are revisiting our health system. Do we have the ability to leverage this simulation software to be able to view the patient's entire care continuum while they're here with us at Memorial? So walking through some of the steps that we ask specifically when we are asked to build a SIMUL8 model for facility planning, when we are looking to build up some new bricks and mortar, the first thing you want to ask is you want to know your inquiry. Now what I mean by this is we really need to know exactly what questions we are attempting to answer. What we've experienced here at Memorial is we've had a lot of great results that have come from SIMUL8 models, and we've made sure to publicize that and sort of show how we can utilize this software. But what that's also come with is people see simulate models, they get very excited, and they think that a simulate model can fix everybody's issues for everything. And while it's a very powerful software, it's something where you need to be sure that you know exactly what questions you are attempting to answer, because it's not going to fix every single issue that you're having on an operational unit. So really having awareness of the model's purpose will save time and effort for everyone involved. For those of you that are on this call that have built simulate model, know that you can build a simple model that might take an hour or two to build, but you can also build very complex models that are very powerful that might take upwards of 30, 40, 50, 100 hours to build. And so making sure that as you're going through this process, you're not stretching it out by trying to fix every single little issue that might be able to be addressed in another arena. One big aspect of that, and we have a little comic strip, a little Far Side comic strip here alongside, is we want to try and avoid confirmation bias as we're going through this process. For those of you that might not be aware, confirmation bias is defined as a tendency to search for or interpret information in a way that confirms one's preconceptions, leading to errors. So we want to make sure that the cornerstone of these models is to be able to explore all of our options, which is why I attempt to, and I try and challenge everybody that I work with that does build simulate models, is to try and start with as much of a blank slate as possible. We've had people that have come up to us and asked us to build a model to confirm that, you know, this is the number of procedure rooms that we need for this area, or this is what, please confirm that this is what we need to do. When in reality, that should not be the purpose of these simulate models. There's a lot more power that's built into this software that allows us to explore outside of the box and not just confirm, again, what's been done in the past. So taking in as much information as you can, but that being said, as much as possible, really starting with that blank slate and exploring what all of your options are as you're going through that planning stage. Next, we want to make sure we know our process. So I function as a Lean Six Sigma project manager, so I process map on a very regular basis, and I found that that is very translatable to as I'm going through and building these models. It is very much a value-added step in sitting down, bringing people together in a room, and building out an actual process map with the stakeholders that work that process every day. In healthcare, I know a lot of times that can be a little bit difficult because it can be hard to pull those care providers off of the floor, whether it be due to staffing issues or geographically where you're located. But we found that there can be a disconnect from what leadership thinks might be happening and what is actually occurring. And a lot of that comes out as you're building a current state process map of how are we utilizing that space now? You know, how are we flowing through that process? How are patients flowing through that process? And how can we make sure that that is accounted for within each of our models? Once you're done completing the current state, I also like to look at future state. You know, have there been opportunities identified as we go through this process mapping exercise to be able to redesign this space to provide the best outcomes possible? So really thinking of it as you're building up these new bricks and mortar or these new buildings, how can you make a space that is efficient for those people that are working in it? And is there the opportunity at this point to launch into a quality improvement initiative to look into and dive into some issues that you might be seeing where you think that there could be opportunities to provide better outcomes? Knowing your space. So facility planning is all about knowing the space that you are provided and that you are working in. So meeting with stakeholders and decision makers within your organization to determine your space utilization. So looking at some of those physical restraints that you have and that you want to incorporate into your model. You know, what we have seen is as we're building these out, we want to make sure we're looking at some of those non-value added spaces, whether they be janitorial closets or restrooms or hallways. Making sure from an organizational standpoint or from an accreditation standpoint, we are building out models and we are giving recommendations that account for some of these physical restraints that you might see during this facility planning process. Also, ultimately, that bottom dollar. So looking at, you want to make sure you identify the fiscal restraints and expectations that are brought to you, because while you might not be the architect, you're providing these recommendations, and you want to make sure that they are based on realistic expectations and that you're accounting for the boundaries that are in place from a fiscal standpoint, and make sure that those are also accounted for in your model. And this is more on a technical standpoint, looking at the actual Simulate software. What we have found is that building a background image of a floor map and building in animations to demonstrate the people or items flowing through the model really helps make these models more translatable to a wider audience. So if you've gone through and you've built a model, you know how each of these resources work and how the distributions work. But that being said, if you've never been exposed to Simulate before, you might not be aware of exactly what is going on as things are flying across the screen. So what we have found is, once we have our model built and we bring it back to our stakeholders, building in some of those specific things within the model really helps these models be more translatable as you present them back to those who are listening to your message. And lastly, one of the most important things as you're going through and building your models is we want to make sure you know your data. So as we all know, your outputs from your model are only as good as the inputs of the data that you are putting in. So what we do is, when we go through and we collect all of our data, we circle back and validate it with people that are working that process. So this sort of links back to knowing your process. And one of the prime examples that we have used in the past is we have built a model looking at our emergency department and the throughputs of patients moving through. And one of the data points we were looking at was looking at our door-to-doc time, or how long does it take for a patient to come in through the door before they are being seen by a physician. Well, we had pulled data, and we realized that there are a lot of different definitions depending on the person's background of what door and what doc time was in this process. So door might be the time from when that patient is physically walking in the front door, or is it the time from when they're checking in with the triage nurse, or is it from the time when they actually get back to the emergency department? So there are a lot of different definitions for different data points. So going back and validating this data with the people that work that process will ensure that you're feeding good data back into your model. And then ultimately, looking at the distributions and give you the ability to customize the data to best represent your process. So for those of you that do work in healthcare, you know that a lot of our data is not normal. It might not be very predictable. And so Simulate gives you the power to be able to build in different types of distributions to represent, whether it be arrival rates, where we might know how many patients we're seeing on average per day or per hour. But that being said, we know that that can really flex throughout the day or throughout that season. So using your distributions to make a very powerful model can really help you during this cause and during your facility planning stage. And lastly, as we're going through and looking at the data that we are wanting to bring in, this is actually a checklist that I use in breaking down our data into 4 buckets. So looking at our entry points and going back to, again, who and what is entering the model and at what rate. Looking at your resources, so the types and purposes of resources, how many of those resources do we have? Availability and shifts in productivity is something that we see a lot as well as we're going through and we're building these new spaces, looking at our staffing models and looking at where our opportunities might be to help elevate some of our clinical caretakers to be able to be working at the top of their license. So is there the opportunity to reassign a RN to work on something else while a patient care tech or an orderly might be able to do something else with that patient? Next, looking at our constraints, so looking at some of our queuing times or the variables that might have an impact on that process. This really comes to light as we go through and we know our process and we build out those process maps and identify those constraints. And then lastly, again, as I had mentioned, knowing your inquiry, what is it that we are looking at? Are we looking at room utilization? Are we looking at turnaround times for rooms after patients have been discharged? Are we looking at counts or volumes as patients move through? So what we found is if we can answer each of these questions with these 4 buckets, we can build a model and bring suggestions back to our facility plannings team, where they can then take that and build out the space and some of the look and what it is that we need in those spaces to create an efficient and effective area for care for our patients. So next, I'm going to walk through 2 case studies that we have walked through these 4 process steps here at Memorial Health System. One is a little more non-clinical, and one is looking more inside the hospital and from a clinical operations standpoint. So I'm going to walk you through how we walk through each of these four steps, as well as some of the results that we saw from our simulate models. So the first was new front circle drive that we were looking at. To give you a quick background, we had built a new 114-bed patient care tower at our 500-bed flagship hospital here in Springfield. Along with this new patient care tower came a new front entrance and a new front drive access to the hospital, where we were having patients, visitors, delivery people that were coming in and out of the hospital on a daily basis all throughout the day. So first, we wanted to know our inquiry. So looking at, with current traffic volumes, what is the best way to set up our circle drive to avoid congestion and maintain safety for employees and patients being discharged? This might seem like a fairly simple ask. You know, you look at it and you say, well, you have people that come in and out, they come through, they drop their patients off, and they keep going. With that being said, as we looked at our process, we actually have complimentary valet service here at the hospital, where we have patients and visitors being discharged and helped to their vehicles. And so what we wanted to look at is, how can we avoid traffic congestion? How can we avoid overbuilding to where we have too much space for cars to come in and out? But ultimately, how can we make it so that way patients can be safely loaded, as well as cross across this new circle drive, to ensure that we're going to avoid accidents or anything like that from occurring. When we went in and we looked to know our space, previous to construction, we had 2 lanes for traffic throughput. This was kind of a unique model for myself, because when I was coming in, this was before I was introduced to Simulate. So my coworker here, Lance, was actually the one that had built out this model, whereas I was working, and I worked and managed multiple ancillary departments, including that valet staff. So I was able to actually come at it from a stakeholder perspective, whereas Lance was coming at it from an operations improvement perspective and building this Simulate model for us. So I was able to sort of see both sides of the coin throughout this process. And lastly, we wanted to know our data. This was also a unique experience, because we did not have this huge bucket of data where, you know, we were able to pull things from left and right, but instead all we had to depend on were some estimates that we received from valet staff. You know, we knew how many vehicles we were parking. We knew a rough estimate of how long it took to park these vehicles and where we were seeing vehicles from. But that being said, we were stuck in a situation where we didn't have a big bolus of data to work from. So I'm going to turn this over to Lance at this point, and he's going to walk through how we were able to overcome some of these obstacles and some of the considerations that he used to build into this model to ensure that, again, we were meeting some of those inquiries and questions that were originally posed.
Absolutely. So as we were building this model, again, going back to the 4 steps, know your inquiry is also not just know what questions you're trying to answer, but to know your audience and understand what their objectives were and kind of the level of rigor that you have to apply. So for those that have done this type of work, if you're working in an academic setting where, you know, the amount of accuracy is paramount, that's a different conversation than where we were working in an operations perspective, where you can allow some level of margin for error for some of these things, as long as there's statistically significant differences in the data that you're looking at. So from that perspective, as we're building this out, knowing that A, our data is limited, and B, understanding that we're doing this from an operations perspective, where we do have a little bit of margin for error that we can work within, that was really informative to the types of distributions that we could do. The other part of know your inquiry is understand what and how people are going to be able to consume. So you see here we've got a lot of visual, And we actually, not pictured here, but we actually built out an Excel front end as well for this, to where people could manipulate the variables and have the simulation run without allowing, having to have an intimate knowledge of how to manipulate those variables. And so really one of the goals was with this in knowing your inquiry was also knowing how we were going to present this data to our stakeholders, and that visual representation of this was going to be important. Understanding our data, we knew that we had some level of observation data, and so we knew that we were never going to be working with a lot of distributions such as the log normal or the Weibull or some of the other distributions that, normal, definitely not something that we have a lot of opportunity to use here within our data sets, but just understanding that it was going to be more time estimates, and that's where we utilized the triangular distribution and the uniform distributions. Those two really lend themselves to, almost for those that have worked in a project management perspective, the triangular is really similar to the PERT analysis in a way, where you're having a conversation with your stakeholders, and if you have multiple conversations with multiple stakeholders, you start to be able to form a good distribution that you can get relatively good accuracy out of. So how quickly, what's the best case scenario, what's the worst case scenario, and what's the most likely? And if there really isn't a most likely, you know that you're using a uniform distribution. If they're giving you 3 options, then you start to build it in from a triangular perspective. And that's really how knowing our data in this situation and knowing that we had some opportunities or challenges rather to our data set made it important to really inform us what type of distributions that we had. And so with this model, the way that it worked out, we knew that our objective was to keep patients' vehicles off of that main road that you have there along the right side of your screen. That's actually First Street here in Springfield, Illinois. And so the objective here is we don't want traffic backing up onto First Street, which we had in the past. And then the other objective was how do we utilize this in a way that was not going to negatively impact our flow of concierge service and our valet parking. So what we came up with was, through several iterations within this model, using the middle lane for anything other than ability for people to flow through, that's really what we came up with. We recognized that we wanted to keep the lane closest to the hospital, which would be the upper left, as open as possible. So those were patients that were going to be parking 5 minutes or less, and that's the operational guidelines that the valet are working under. They meet the patient if it's going to be a longer stay or a longer parking where you're actually going up and getting the patient, or you need to have some conversation with a provider real quick, or you're dropping something off that might take more than 5 minutes, but it's not something that where parking across the street, so that's what that outer lane is. The other thing that we knew is that we had commercial traffic in addition to patient traffic. So we had couriers and different things dropping things off. So that's what those trucks are. And then finally at the very bottom, for those that are in the United States, we have our traffic laws that allow permission to turn right on red or turn right out of a right turn lane in many circumstances. And really the question was, okay, do we put that straight to go across the traffic in the right-hand lane or the left-hand lane? And based off of observation data that we had and some of those conversations with our subject matter experts, we were able to model even down to that level of detail. That, okay, if we put that straight and if we used a straight right combination, you're going to have more backing up of traffic because the vast majority of people were trying to turn right, and the fact that they legally can do so, you're really going to back things up, versus there was a lot less traffic that was turning left to cross traffic or go straight. So we decided that based off of the models and the results that we had out of this model, that it made a lot more sense for us to have the left straight combination out of the circle drive. And so that's really the results that we came out of this. The other thing that's nice about this model from a visual perspective is SIMUL8 allows you to changed the icon based off of a distribution. So we actually, the trucks are actually a truck variable, or the vans that you see there, and the cars are actually a passenger variable. And so we could even change the distribution of commercial traffic versus patient traffic and see not only from a numbers perspective how that would impact it, but we would also see visually how that would be impacting things. And for those that are more visual, it was really a helpful way of giving multiple ways of interpreting the information for our stakeholders.
Thank you, Lance. And I know I can speak from an operational perspective as well. We identified that a lot of those vans, which were represented by flower delivery people, food delivery, some equipment delivery, we actually ended up, based on this model, we decided to move as much of that routine delivery back to a different entrance to the hospital as well, to ensure that we left as much space for our patients and for our visitors to be able to come in and out of the main lobby of the hospital as possible. So there were some operational repercussions as well that came from this model, where we were able to identify how we could best serve our patients. The second case study I'm going to walk you through was looking at one of our small critical access hospitals. For those of you that might not be familiar, here in the United States, we have critical access hospitals, which are 25-bed hospitals located in rural areas. But we had one of these critical access hospitals that was wanting to rebuild out a portion of their hospital to centralize 5 different testing areas that were previously scattered throughout the hospital. So looking at their infusion services, their pulmonary function testing, their sleep lab area, their radiology exam area, and then an area for just general exams. And they wanted to bring that all together into one 2,600 square foot space to be centrally located towards the front of the hospital for patients that were coming in and out for some of these outpatient diagnostic tests. So we started off, we wanted to know our inquiry, and we were posed with looking at, given our current volumes, how much space do we need dedicated to each of these testing areas to avoid long wait times for patients, to avoid any throughput issues as patients moved through. And the second thing we were looking at was, we were posed with the question of, would we be able to register patients in the room without causing significant issues for the throughput of patients. So I'll touch on this a little bit later, but really what this came from was we had noticed some declining patient experience scores, and a lot of that was could be linked back to our registration process. So we used to be in sort of your traditional registration process where a patient would come in, they would check in at a check-in desk, they would receive their papers that they would fill out, and after 15 to 20 minutes they would be called back to the procedure room. Well, we wanted to see if there was any way to be able to alter this to improve the patient experience as the patients move through this process. So again, knowing our process, we had that more traditional waiting room setup, but we wanted to take a look at, could we move that registration portion of their care back to that care room where it'd be a little more private, and have the ability to have the registrars go to those patients as opposed to vice versa. Secondly, we wanted to look at our current scheduling for our sleep lab studies. We found that that was inefficient. That, again, came from, as we were looking at our current and future state process maps, we noticed that there was a long lag that was resulting in cancellation or delays in some of our sleep lab studies. So we wanted to focus in on that as well to see if there was the opportunity to shore some of that up, to drive volumes, as well as drive some revenues by getting more patients into the door for those studies. Knowing your space, so again, we were posed with a general outline or a blueprint of what they were looking at. We knew we had approximately 15 rooms, looking at our square footage and the regulatory standpoint of how big we needed these rooms. We knew we had about 15 rooms that were going to be divided among these 5 services. And then lastly, knowing your data. So this was another unique situation where we were building this model, but realized we had very, very small hourly volumes, where some of these procedure areas might only be seeing 1 to 2 patients a day, or even 1 to 2 patients per week. And so we had to look at this in a different angle, and how do we build this into the model where we might not be seeing a patient every single day, but what is the logic that we can build in to be able to leverage this software to make it as realistic as possible as patients were moving through this area. So again, I'm going to turn this back over to Lance and how he was able to use some of his Simulate knowledge as well as some of his statistical knowledge to build this into the model to represent appropriate hourly volumes and patient arrival rates.
Absolutely. And so when you're looking at this model, there's a lot of different disparate patient populations that we have in one particular area. And if this was one specific situation where we had a homogeneous amount of patient population, that would have made things a lot easier because there's some standard functionality in Simulate where you could manage those distributions. But the fact that we had phlebotomy patients, which they're seeing, you know, several dozen a day, and you've got sleep lab patients where you're seeing maybe 1 to 2 a night, and you have certain patient or pulmonary function testing and certain other infusion services, or maybe they're doing 1 or 2 a week. Those created different problems based off of the fact that you've got these disparate patient populations coming in. And so part of the nice thing and part of the challenging thing about Simulate is the fact that you can make these as simple and complex as you need them to be. And so for those of you that are new to Simulate, some things that, and we've actually had a webinar, you know, last year on some of the steps that we do to build out a program, and I'd encourage you to go through the Simulate archives and take a look at that as well if you're interested. But one of the things that we talk about is to make sure that in your area that as you learn and build out your Simulate program, that you identify some folks that can maybe take advantage of some of the more advanced capabilities that Simulate have, because it's a fantastic program that really allows you to get into a lot of the nitty-gritty details. And one of those functions is something called visual logic, and it's a way for you to go in and build custom programming that's you know, stepping above the things that are normally provided, which again, Simulate does a fantastic job of giving you the vast majority of the tools that you need. But in this particular situation, whenever you were putting in patients that were seen every other day, a lot of times what would happen is, and just again for additional information, the way Simulate works is that the next patient or the next work item is scheduled at the time that your work item is coming into your work stream right now. And so, for example, if we had set up 2,400 minutes or, you know, a day and a half as the average time between 2 work items, then you're actually going to run the risk that Simulate is, you know, going from day to day is never going to pick up that next patient, again, depending on how you set up your clock. And there's a lot of details here that, that go into this. But really the point of this is that you can set Simulate up through visual logic to actually force it to look at things from a probability perspective as opposed from a specific timing perspective. So instead of saying there were 2,600 minutes between our next patients, essentially what it was is okay, you've got a 15% probability that a patient is going to be seen today. And just that shift in how Simulate is working with the model, it really allows you to become much more accurate in getting those patients to come through. And so, you know, there are ways that you can go about making Simulate look at things from a different statistical perspective through visual logic, and I would really encourage all of you that are wanting to take Simulate to the next level in your organization to find that person or that resource in your organization that can really invest the time in learning the visual logic functionality and allowing that customization to come into place with the model. And so this model here really is a great example of how you can have multiple different disparate distributions coming in from those work items that are being seen on an hourly or maybe even minute basis, and those patients or those work items that are coming across maybe a couple of times a day or even once or twice a week, and you're still able to work within the same confines of the model, but really treat those different populations in a much different way. And again, for those of you that are in healthcare and really reaching back, you know, in the United States we have something called STEEP, and really it's trying to be safe, timely, effective, efficient, equitable, and patient-centered. And these customizations are key to be able to get into those things that are patient-centered and really to customize the care to the types of patient populations that you're working with. So to wrap up this is really knowing that there are much more advanced models that you can build and simulate than even the excellent standard functionality. And again, I don't want to take away from that. There is, you know, an awful lot that you can do with the standard. That whole previous model that we talked about with the Circle Drive, outside of the Excel interface, that was all standard functionality that we had there. But then also to jump into something like this where it's much more unique. The other thing in this model that we did is we built in revenue and cost. And so taking advantage of the standard functionality that Simulate has for giving a standard revenue and cost to a work item, that way we could really test not only throughput, but also test the margins and test volumes. And okay, where's the break even where this project doesn't even make sense? So you need to have a certain amount of patient volume before you're covering your variable costs. So for those of you that have more of an accounting background, again, there's a lot that you can do in Simulate to offer that type of information to your stakeholders so that you're not only catering to the operational folks that are trying to make this work from a day-to-day perspective, but you can also really offer information to your financial folks to say, okay, we can really test contribution margin. We can test some of these financial ratios to see what is the true ROI and what would the net present value be on some of these types of projects, and can we make some projections on if we were able to grow our volume, how does that change the financial projections of a project in some form or fashion.
Thank you, Lance. So to continue on to that, what were some of the results that we saw that came from this model? Again, looking at some of that registrar and that registration staffing model, we were able to identify that, you know, we were not going to slow down the throughput of patients, and we were able to put one receptionist up front that would greet those patients and do a quick check-in and lead the patients back to the room where they were being provided the care. And then we were able to build in registrar staffing that would float throughout each of these units that used to be in 5 different areas of the hospital, to where they were centralized in one area of the hospital, and we were able to take some of that other registrar staff and float them to other areas where they could be better utilized. We were also able to recommend the number of rooms per specialty in order to maximize space utilization. So again, when we're looking at square footage layout, we got a cost estimate of about $500 per square foot to build this out. When you look at the average room was about 163 square feet. We were looking at, again, each of these kind of boxes or these rooms was going to be about $82,000 to build. So we wanted to make sure we weren't overbuilding, but we also wanted to make sure we were not underbuilding. We were able to identify, looking at current volumes and patients flowing throughout, that we actually had a primary exam room that would be used during the day for some of those more general exams, and we were able to create it so it was a hybrid as a sleep room during the evenings when some of those sleep lab studies were being done. And then lastly, as I had mentioned, the value of going through and process mapping, we identified that our sleep lab scheduling process was fairly inefficient, and we had some opportunities there. So as they are currently building out this physical space, they are also launching a quality improvement project that has a projection of potentially $100,000 annual increase in gross revenue that could come from, if we shore up some of these issues that we're seeing in our sleep lab process, we could grow volumes and we could decrease our cancellation and our no-show rates to, again, be able to experience growth in volumes as well as growth in revenues. So those are the 2 examples that I wanted to bring to you. Again, I want to thank everybody online, including Simulate, as well as Lance here in the room, for listening as we sort of walked through our process. If there are any questions right now, I'm going to turn it back over. There is my contact information there listed on the screen, so if you do have anything in the future where you might want to know, again, how we use some of these aspects of Simulate or how we walk through our process, please feel free to reach out and ask any questions.
Excellent. So thanks again to Graham and Lance. It's really good to see how you've built up a methodology that's going to help ensure success throughout any simulation project, and it's really good also to see that applied to such a varied range of projects. I think you've really done a lot of good in utilizing the flexibility and the power of Simulate. So we have had one question so far. Do keep asking questions if you have any more. And that is from Rebecca, and she asks, in terms of the projects, I guess any of the projects really, were patients involved in any of the decision making, or did they do any kind of observations of the traffic flow?
We utilize simulation a lot here at Memorial, as well as we have an entire building fully dedicated called the Memorial Center for Learning and Innovation, and we actually have two different types of panels where we receive patient feedback from various quality initiatives or operations improvement projects that we've worked on. And so we use that and meet with patients. I believe it's once every 2 months, and these are volunteers that come in that have either been patients in the past or our community stakeholders, and we have brought some of these models to these patients for them to look at, for them to see, how we're utilizing not just simulation and bedside care, but also how are we utilizing it from this facility planning standpoint. And so it gives us a great opportunity to bounce that off of people that might be outside of the organization or might be coming at some of these issues that we experience, with a different mind frame. And so we've found that that platform has been very effective to reaching out to the general public.
And if you go back to some of the points in the steps, knowing your data and knowing your inquiry, those are important things. And so actually, when it came to the critical access hospital project that we had talked about, that was where actually some constraints that were presented to us even before we started the project. And so leadership at that critical access hospital had reached out to their patients, and they had understood that some of the things that had bothered the patients were the amount of walking that they had to do between different tests and the amount of confusion to try and find 4 different places when they're trying to get 4 different tests done to be ready for their surgery tomorrow. And so that, I think it's great to as Graham pointed out, bring the actual models information to the patients, but I'd also encourage you to try to have an understanding of what those constraints are from your patients even before you start the process of modeling, because you want to make sure that you're taking their thoughts and information into consideration when, Graham had that slide with the different pieces of data, and constraints was one of those. And I would consider patient satisfaction to be an informative source of information for those constraints. So try to make it a part of your process to even reach out to your patients in the initial forming stages of these, and have those as a part of the constraints that you build into your model.
Great, thank you. And we've got one more question through, asking how many projects in total have you guys done?
From a simulation perspective, and again, just as a little bit of additional history, we started using simulation really probably in 2011 and 2012, but recognized, and again, that webinar that we did last year goes into some of these details, but we really recognized that we weren't getting the full power and return on investment through the balkanized approach that we had taken with our use of Simulate. And so really in 2015, it was actually my black belt project in Lean Six Sigma to really bolster our use of Simulate. And at that point, we saw a huge explosion of the different projects. And so I believe the total is somewhere in the 30 to 40 range over the last 2 years of different models that we've built out and different projects that we've done, ranging from use of the different resources in the emergency department with CT scanners and evaluating, everyone says that you need to go out and buy a new CT. Well, those are not cheap. And so can we learn how to improve our processes of care to get better utilization? We've done things in our home health. We had some good projects in looking at how we structure our teams that go out to our home health patients, and really looking at where does it make sense to put our borders for how far we go out based off of the cost of care with RNs versus LPNs, which is a different designation of clinical expertise in the nursing perspective, and really understanding, okay, drawing our borders for these different teams and taking into consideration how far the different towns are. We've done projects in our ORs. Specifically, we've done some things in of most interest would be block scheduling. We understand how that's difficult, but being able to do what if scenarios if I give one physician more block time than the other based off of the types of procedures that they do and the level of you know, their outcomes and, you know, the cost and contribution margin to your hospital, and being able to use Simulate to do those what-if scenarios to see the true impact to your organization. To things like the circle drive and the facility things that we've talked about today. When we opened our tower, we did a project on some of the, you know, how do you, the square footage that nurses were covering, I believe it was tripled. And so that's a lot of square footage for a nurse to try to be able to cover. So how do we properly assign nurses to where they are not going to be impacted by this additional square footage? So just some additional ideas that we've done, but we've probably done somewhere in the neighborhood of 3 or 4 dozen projects associated with Simulate. And there's you know, we've actually built it into our methodology and our governance process to where when a new Lean 6 project comes in, or from a facility perspective comes in, we actually asked you, do you feel like there's the possibility of using Simulate? And it's built into our governance. It's built into how our belts are trained here at the health system. All of our black belts are trained in the basics of using Simulate. And so really getting more people that are using the product is really key. So that's a long answer for we've done you know, 3 or 4 dozen, but I wanted to add some additional context to the breadth of experience that we've had with this product.
Excellent, thank you. And it's great to see, as I say, such a wide variation of processes that have been simulated and such varied value that you've got from the tool. We have got some additional questions on the chat panel, but I think it's probably easiest if we can come back to these and carry on the conversation. We will make sure that we post any of the questions on the Simulate in Health LinkedIn group. Also, there will be a recording available at simulatehealthcare.com. And if you do have any further questions, can people contact you guys, Graham and Lance?
Absolutely.
Fantastic. Yes, of course.
Brilliant. So thanks everybody for listening. Thanks again to our presenters. Great presentation, and tune in again next month.
Thank you so much.
Thank you.